lot of people don't need to be in the hospital. And that's the highest cost of healthcare. The ERs, the hospitals, trauma centers are famous for losing big money. You got to have all the specialties on call, and you got gunshot and stab wounds and whatnot. And you have a lot of people with no insurance or public aid if they're lucky. So, and there's an over reliance on nursing homes too. Not everybody needs to be in a nursing home. They might just need a little help. I mean, we can provide a lot of services that they can get at home, whether it's hospital bed, oxygen, visiting nurses, physical speech occupational therapists, and it could be done at a fraction of the cost. And most people would prefer to be at home. There's no place like home.
Hello, and welcome to Let Care Speak. I'm your host, Anyata, and today we're talking with Richard Ansfield, the president of In-Home Physicians, a house call medical practice that has been serving patients in their homes since 1989. Richard has spent 35 years building a model of care that brings doctors to patients instead of making patients travel to doctors. Richard, welcome to the show.
Thank you. Thank you. Glad to be
Yes.
here.
So take me back to 1989. What was the vision when you started In-Home Physicians? What problem were you trying to solve?
Sure. Well, basically, I remember when I was a kid, my father made house calls. He was a physician, and it became a thing of the past. I had a broken leg and was in a plaster cast, and basically I was supposed to follow up with the doctor, and it's like I was a turtle laying on my back with a plaster cast from my hip to my ankles. And Dad, don't they make house calls anymore? Oh no, they don't make house calls anymore. And I figured there was a demand and need. So basically started a house call program with doctors that had some availability and patients who needed the service. And it just grew and grew over the years. And now there's more organizations that are making home visits. When we were doing it, we didn't know of anybody else doing it. So we were
Mm,
pioneers in the field, so to speak.
I love it. That's so beautiful. And so speaking of pioneers, Richard, take me back to those early years and what did you learn in those first 5 years that shaped how In-Home Physicians operates today?
Sure. As I like to say, learning's expensive. I can't afford to learn anymore. But this is pre, obviously, electronic medical records and electronics. So they're the old paper charts and whatnot and everything. That's when the doctors still wrote prescriptions. So it was pretty much in its early stages. The nice thing about the doctors is we would tell them the patients weren't going anywhere. They could be scheduled based on the doctor's availability. So the flexibility was a selling point for us. And a lot of the patients remembered when all doctors made house calls, and they felt they could tell a lot about a patient by their living environment and whatnot. And a lot of them were social. They used to say a mother could take care of 6 children, but 6 children couldn't take care of one mother. So they were like the forgotten ones, and none of the people wanted to be a burden on their children. So we started off, with paper charts, and everything was analog, no digital. And since it's been much better, obviously, and a lot more efficient with the electronic medical records. But house calls are good. They're not profitable because there's a lot of travel time and non-compensated time. You can see a patient in your office and bounce from room to room versus traveling in the field. And a lot of times for the people, it's almost a social thing for them. They look forward to it. They're lonely. And the doctors
Yeah.
enjoy it too.
Yeah, that's a nice reprieve from the four walls every day too. And they
Exactly.
may get some goody treats too.
Right. And a lot of stuff can be done in the home now, which is nice as far as
Mm-hmm.
diagnostic testing, imaging, blood work. So we can do a lot in the home, not MRI or CT scans, but everything else pretty much.
Yeah, and that's quite comprehensive.
Sure.
So, so we're talking 35 years and you're still doing this. What keeps you committed to house call medicine when the healthcare system has moved in a completely different direction?
But it's also coming back. I mean, you're seeing now hospital at home, you're seeing remote patient monitoring, chronic care management. Ever since COVID, a lot of the people did telehealth, and Medicare is reimbursing for telehealth. So it's like old fashioned medicine, I feel like, with today's technology, if you will. It's like the return of the house call.
Oh, nice, nice. And so I'm curious because it is slowly coming back and everything. And is this type of medicine or medical practice accepted by insurance? Is that covered with that?
Oh, sure. Medicare, especially.
Okay.
Obviously, it's cheaper to care for somebody in their home than to be in an institution. And our whole goal is to keep people as independent as possible and keep them out of the hospital and keep them out of a nursing home. And it just makes things better for them. They don't have to inconvenience family, friends, a Medicar, transportation's an issue. Our weather in Chicago in the winter isn't the best. So it seems like it's getting more of a resurgence. There's the American Academy of Home Care Medicine, which was formerly called the American Academy of Physicians. But since a lot of mid levels, physician assistants and nurse practitioners are also going out and doing it. And we're also very involved with the Home Care Centered Institute here in Chicago. So things are moving along and progressing. And I think the house calls are becoming more profitable. I mean, I've talked to administrators of large hospital groups, and they could build the hospitals and they could build the clinics. But the homebound bedridden patients, if they can't get to them, and the sickest 5% of Medicare beneficiaries use 50% of the resources. So they're not being addressed. Their needs aren't being addressed. So we're trying
Mm,
to fill the gap a little bit.
I think that's a big gap that you all are filling. And I just want,
Absolutely.
yeah, and I just want you to know you are doing beautiful work.
No,
You're
doctor,
creating that access to care that
sure,
some people, didn't even know that that option was available.
exactly. And we're just seeing a lot of people don't know what services are available or how to obtain them.
Mhm.
The doctor, the provider, is the one that has to order everything and sign a certificate of medical necessity, whether it's for prescriptions, whether it's Meals on Wheels, whether it's a social worker. Uh, there's so many services out there. Pharmaceutical assistance plan. They might be on a fixed income. Should I buy food or should I buy medicine? They can't do both. So we see the whole gamut of patients. Uh, So, from very wealthy people that have 24-hour nursing care to people living alone on a third floor
Mm,
walk up that are prisoners in their own home, basically. They just can't get out.
hmm. Damn. And so speaking of that, Richard, you work with patients, managed care organizations, nursing homes, hospice, all of the ones that you previously mentioned. And
Right.
those are yeah, those are a lot of different stakeholders here. And so how do you balance all of that? And what would you say is the common thread?
Well, we get a lot of referrals from social workers, discharge planners at hospitals. Uh, we get intake sheets from other physicians, Department of Aging, Department of Disability, Department of Human Services. A lot of times the doctors are overwhelmed. They're getting calls from family, pharmacy. The patient's not able to get to their clinic to visit them. And it's like risk benefit. It's time consuming. They'd rather have somebody be their eyes and ears, if you will, going out to see them and manage that patient. So we get a lot of referrals from, different people. Now online, they find us a lot too. You got a son or daughter in New York, California, and they look for, you know, visiting physicians, if you will, in the area to see their mother. And then we often call them after the visit, or sometimes they're on speakerphone during the visit. Uh, and a lot of them can't do the telehealth too because they're not computer literate. They don't know from Zoom. They don't have a smartphone.
Mm.
I mean, I've seen a lot of more black rotary dial phones in some of these patients' homes. It's like walking in to something 50 years ago sometimes. But
Yeah,
it's
I could
interesting.
imagine.
And people are living longer.
This is
10,000
what I love
people.
to hear.
Yeah, 10,000 people a day reach Medicare age. 10,000 a day, every day.
Mm,
A lot.
yeah, it is. Wow. And that's something to think about right there.
Absolutely.
Yeah, yeah. And since we're talking about that with Medicare and 10,000 every day, 10,000 people, receive Medicare, you know, I'm sure you've watched this transition of just medicine and insurance and, and all of the changes there. And, I might be pressing some buttons here, but based off of your observations, what would you say is broken about how we deliver primary care and what needs to change?
It's costly. I mean, I remember in the old days, Medicare didn't pay for a flu shot, but they
Mm,
paid for hospital admission. There was no cost containment. There was no preventative. I think in the future, you're going to see a lot of the income is going to be gotten by outcomes. I think that, there should be an incentive, even with these accountable care organizations, to save money. Now they're doing hospital at home. A lot of people don't need to be in the hospital. And that's the highest cost of healthcare. The ERs, the hospitals, trauma centers are famous for losing big money too. You got to have all the specialties on call, and you got gunshot and stab wounds and whatnot. And you have a lot of people with no insurance or public aid if they're lucky. So and there's an over reliance on nursing homes too. Not everybody needs to be in a nursing home, skilled nursing home. They might just need a little help. I mean, we can provide a lot of services that they can get at home, whether it's hospital bed, oxygen, visiting nurses, physical speech occupational therapists, and it could be done at a fraction of the cost. And most people would prefer to be at home. There's no place like home.
I agree. I agree. And if I could, I would sign up for that too.
Absolutely. Well, you're not ready
Yes.
yet.
No, not yet. Thank goodness, Lord willing. Whew. But Richard, I've often seen how patients leave care settings very confused about their health, which is why I built an app to help with that. And so, from your experience, where do you see that gap understanding? I'm sorry, where that gap in understanding show up, and how does clarity impact outcomes?
Sure. A patient is discharged in the hospital and they're told to follow up with the physician a week, 2 weeks, and oftentimes they don't. It might be a transportation issue. They might have to inconvenience family, friends. They might need a Medicar. That's what we see a lot. So they're not following up. And the hospitals can be penalized if a patient comes back with the same or similar diagnosis within a 30-day period as well. Uh, but that's what we see. And the caseloads are bigger and bigger. There's not the continuity. It's like the old days. You had Marcus Welby, the old general practitioner who would see him at the clinic and follow up in the hospital. Now there's hospitalists, hospital-based physicians that see the patients and managed care. So I think a lot of the patients don't understand. A lot of the times they don't know. A lot of times the providers are spending more time at the computer than they are with the patient face to face, is what we see.
Mm. Yeah, and we're working to shift that because we need to devote more time to the patients and less
Sure.
the
Absolutely.
computer. So hopefully we can continue implementing technology so that, patients do have a greater voice and greater visibility and just a
Absolutely.
stronger connection with their healthcare professionals and providers. Yeah, yeah.
For sure.
And so, Richard, you were recently selected for the Illinois House Call Project. Congratulations.
Thank
And
you.
that aims to bring home-based primary care to 3,000 plus patients. And
Correct.
that's huge. And
3,000
so,
more patients additionally.
yes, yes, additional 3,000 patients. And so, what does that mean for in-home physicians and why is that moment important for house call medicine?
Sure. Well, we're always looking for more providers to make the home visits. And it's a special calling. Not every physician wants to make home visits or house calls. Finding the patients, I think, is the easy part. finding the providers to go out there and service these patients has been the challenge for us, to be quite frank with you, and everybody, uh, because there's a shortage of docs. There's a shortage of nurses. There's a shortage of CNAs.
Mm.
And they can see a lot more patients in a hospital, nursing home, clinic than they can in the field, obviously. So, but there's a demand, obviously, and a lot of the doctors and providers find it very rewarding. And it's why they became a doctor. And the patients appreciate it. And it's, like I said, old fashioned medicine.
Mhm. Yeah, yeah, and what I'm hearing is incentivizing this for the physicians, and maybe then they will start gravitating towards home health care.
Sure.
Mm,
Well, the
yeah,
mid-levels help. I mean, one time that we only had doctors, MDs, and DOs. Now we have a lot of nurse practitioners as well as physician assistants,
okay.
and that helps the extenders. And sometimes the lowest skill level, the patients appreciate the most. The doctors and the nurses are in and out, the therapist, but they like the person who's helping them with washing and bathing and personal hygiene and washing their hair. They feel better. Uh, we have podiatrists that go as well for the diabetic patients and their toenails, and we have
Mhm.
dietitians that go. We've had psychologists go because a lot of the patients are very depressed as well. There's nobody left, and they don't want to be a burden on anybody. So
Hmm.
I don't know.
Yeah, yeah, and
Y-
changing that narrative from a burden, to making sure that their healthcare needs are met. I think that's important too, because no,
Absolutely.
they aren't
Ab-
burdens. Yeah.
Absolutely. But I don't know of any patient that wants to go into a nursing home, if you will.
Yeah,
Uh,
no, yeah, you're right.
I mean, who wants to? That's a conversation sometimes for the family and whatnot, but we try to keep them out of the hospital, out of a nursing home, and living as independent as possible. Uh, a lot of times they just, you know, want to talk, want to feel, they just don't understand it. They remember, like I said, a long time ago, and people are living longer. I mean, we probably have over 100 patients that are over 100 years old,
Oh,
really.
wow.
And a lot of
Oh,
them were very good.
wow.
They said until their mid 90s. So,
Yeah, you weren't joking when you said that they live longer.
oh no,
Wow.
absolutely. I just saw my aunt last weekend, and she's 98 years old, but she's a good 98. I told her if everybody was like you, we'd be out of business.
Wow, what a
Truly,
blessing. Yes. You all hear that? Home health care saves lives, it prolongs lives. So you better get on it.
absolutely.
So, yeah, Richard, speaking of that, what do you see, excuse me, home healthcare medicine going? Do you think this is something that's going to expand across the country, or do you think it's just going to be like a specific niche?
I think it's expanding. I think it's expanding already. I think it has to expand. Although I don't have a crystal ball, but it is definitely expanding. There's a tremendous need.
Hmm.
Baby boomers like myself are aging, and I just think that there's a tremendous need for that. Like I said, the hospitals can have the hospitals and the clinics and whatnot, but if they can't get to the people, we're seeing a lot of hospital at home now and remote patient monitoring and just so many different things compared to what it was 10, 15, 20 years ago.
Mm.
And I'm just excited to see, and hopefully we'll be able to see where it is 10, 15, 20 years from now.
Oh,
I think it's
yeah.
only going to grow as the population grows and ages. And you
Mm.
can be care for somebody, like I said, at a lower cost. It's how we're choosing to spend our healthcare dollars.
I like that. And if you could sit down with the hospital administrators or the insurance companies and policymakers, what's one thing you want them to understand about home-based primary care?
I think they understand. I've talked to hospital administrators and I said, you don't want the patients to come back, you know, for the same or similar diagnosis, you're penalized. And sometimes the hospital administrator looks me in the face and says, What, it's better to have an empty bed? They got their fixed expenses, they got their value, you know? So,
Yeah, they got their
and then there's
quotas.
managed care
Mhm,
where you basically get paid the physician per patient per month, and you
mhm,
want good, healthy people that don't utilize services. And if you get somebody that's very sick and utilize a service, you want them to go to another HMO or to stay on Medicare because you lose money on those patients. So they're
mm,
cherry picking too a little bit.
I see.
That's the problem,
Yeah,
you know.
yeah, yeah,
And then there's people that have no insurance. So I don't know if everybody has the same coverage. You got public aid, you got Medicare, you got HMO. The government wants to put more people in HMOs, that's for sure. And during open enrollment, at least they know what the costs are,
mm,
period. Uh, but I don't know. I mean, the richest country in the world, yet we have a lot of people with no coverage or no insurance or, or expand Medicare. And then I see a lot of doctors now that don't even want Medicare, don't take Medicare. They won't take any new Medicare patients, but they'll service their existing ones. Or I see a lot of concierge medicine popping up where we'll limit our number of patients, just pay us $2,000 to $5,000 a year, you know?
mm.
So I think it's not fair. Not everybody can afford. Look at these assisted living facilities. They're expensive. They charge more than most people make.
Yeah, it's like
So,
college tuition or something, like Ivy League tuition.
absolutely. And then we're seeing a lot
Yeah.
of sandwich generation. The mother has young children and then she's got mom or dad. So
Yeah.
it's not easy.
Yeah, it sounds like an uphill battle, when it comes to that. But you're putting up a
Absolutely.
good fight, and I wanna
No,
commend you for that.
no, I, I appreciate it. I'm not the only one, but we were one of the first in Chicago, that's for sure, and one of the first early ones in the country. Now there's a lot more than there used to be. That's for sure, because it is growing. And,
Mhm,
and I think the whole medicine healthcare landscape is changing. Most doctors I know now, they don't want their children going into medicine. It's not, shall we say, as good as it used to be.
mhm.
You know,
Yeah, yeah, burnout is real.
absolutely,
Yeah.
absolutely. And
Mm,
it's just very difficult. And you're going to school for a long time. You got huge student loans and debt. And there's very few doctors that are in private practice these days. Most of them are
mhm,
employees of hospital groups, insurance companies, HMOs. And like I said, it's not as good as it used to be. But I think in some ways it's better. There's more women now in medical
mhm,
school than men, law school,
mhm.
graduate school. And I think that they're more, I don't know, empathetic, shall we say, and
Yes, we
caring
are.
more, and maybe not as
Yes.
money motivated. Really?
Yeah, no, it's just that's just a bonus, but yeah, no, you're absolutely right. I can attest to that. Yeah, we have more sympathy and empathy, and we're nurturing when it comes to
Caregiver,
care.
absolutely. I mean, I knew doctors that
Yeah.
followed the stock market closer than their patients.
Mhm.
I mean,
Yeah. It's the same. So yeah, Richard, for those who are listening and are interested in home-based primary care, how can they engage with this work?
well, we're in-home physicians. We serve all of Chicagoland, not just Chicago. We go south to Indiana. We go north all the way, Lake County, east to the lake, and way west. And our phone number is 773-774-7300. That's in-home physicians. And our internet, we have a website too, in-home physicians. And if they know of anybody who could benefit from our services, that's the most important thing. Usually it's not the patient themselves. It's a neighbor, it's a family member, it's a son or daughter. Like I said, it's a social worker, discharge planner, pharmacist. We were getting more referrals now from the fire department, which was surprising. The EMTs were getting calls frequently at the same place. Person fell down, patient wasn't taking your medicine. So we get referrals from all different places. And we try to visit them on a monthly basis. We're not an emergency service. If it's an emergency, of course, call 911. But we try to visit on a monthly basis to monitor their progress and condition. Some of the patients we've seen haven't seen a doctor in years, haven't had blood work current. They don't even know about new medications that are out there. They were taking, aspirins or whatnot. And there are a lot of new drugs now. And some of them just have, they're depressed. They have a bad attitude. Oh, nothing will help. So trying to bring a little light into them. Interested in working with us, that would be wonderful too. Any nurse practitioners, physician assistants, MDs, DOs, podiatrists, absolutely, we welcome them with open arms.
And before we go, is there one thing that you want people to remember about what you do or why it matters?
Well, I think it's very important. Like I said, I think information is the key, and a lot of people do not know what information is available or how to obtain that. And I feel like the provider is the quarterback, if you will, because they know what things are available for the patients where the patients don't know, whether it's helping, they might qualify for Medicare, Medicaid, and Medicaid can cover the things that Medicare doesn't. The drugs, the supplies, bathroom grab bars, diapers, catheters. There's Illinois Pharmaceutical Assistance Plan that if their income is below a certain amount, they're entitled to medication that's covered. So that's what a lot of people don't realize. And they don't know how to obtain certain things and to get certain things. And, they might not have a family or a big support group and they don't want to be a burden and they might have limited resources. So they don't know maybe what's available and what they're entitled to. And that's what we try to do, let them know and plug them into the system, so to speak.
I love that. Are you familiar with gethelp.org?
I'm not.
Okay, yeah, it's a website that essentially breaks down everything you just shared, and the person would type in what exactly they need, the location you can do within a 20-30 mile radius.
Really?
If you need transportation, yeah, I'll email you that link.
But I was not even familiar or aware of that
Mm,
organization. And
okay.
if I'm not being in the field and in the industry for so long, I'm sure many of the other individuals aren't either.
Yeah, that definitely comes to mind. And so I'll send that to you separately for you to check out. And if you're not on there, I'm going to see if there's a way that your services can get listed there too, because I think that would be really instrumental just
That
to
would be
bring
great.
that awareness there.
Sure,
So
that would be great.
35 years of bringing doctors to patients' homes instead of making patients travel to doctors. That's a different vision of healthcare, one centered on dignity, relationship, and real understanding. You're proving that this model works, and now you're expanding it to reach well over 3,000 more patients through the Illinois House Call Project. This is
Exactly.
exactly, yes, and this is exactly what Let Care Speak is about. Healthcare professionals who are imagining how we care for people. And listeners, thank you so much for tuning in. And Richard, thank you so much for your leadership and your
My
vision.
pleasure.
And
My pleasure.
remember, yes, and remember that better clarity leads to better understanding. Until next time,
Absolutely.
everyone.